Now Michael helps practices transition to value-based care by expanding the chronic disease programs to the rising risk populations. So welcome, Michael.
Thank you. Can you guys hear me well? Awesome. Appreciate that. So I've done this presentation 2 of the times at different MGMAs this month. And I can just say I'm so honored to be with you guys today. This is my home state. This is my home chapter. My career has grown with you guys. My family has grown with you guys. 2015, my first Virginia MGMA conference. Drove down to Norfolk, and my wife was having Braxton Hicks with my oldest son, and thought about having to turn around, and I wasn't able to come to 2017 because my other son was born on September 17th. So I am so excited to be with you guys. It's awesome to be here, and after 2 years of not being able to see everyone quite the same way, it's an honor to be with you here in person. In fact, I'd like to, if you guys don't mind, just sending out a huge thank you to Jody and the board for putting on this event. Thank you guys so much. So as they were just discussed, my name is Michael Dudley. I'm with Good in Health. Today we'll be talking about value-based care. We'll be really talking about the full spectrum, everything from population health to what you guys can hopefully come back to your practices and have some practical steps on what you can work on. Just a disclaimer, I am not an attorney, and if you would like to pursue value-based care, I would highly recommend you talking with your internal, external counsel. And as my background, I work for an organization who provides population health infrastructure, the technology and people to stand up population health programs using chronic care management. So just a full disclosure on who I am and what I do. So as an agenda of what we'll be discussing this afternoon, we'll talk about, first of all, where is healthcare today? And then from there, we'll kind of take 2 different sections. One is what changes need to be done to redirect the cost trajectory. What changes need to be able to be made today to be able to redirect the care trajectory. And then part 2 will be actually giving you guys some philosophical and practical steps for you guys to be able to take back to your practices, health centers, and ACOs. So I think it's really important for us to discuss where we are today before we talk about what's coming in the future. I'll try to skim through some of this because most of you are pretty familiar with these stats, but healthcare as a percentage of GDP is 20%, meaning 1 out of every $5 spent is on healthcare. Unfortunately, it's just not sustainable. Something needs to happen. Many have coined the phrase that it's called sick care, not healthcare. Well, you think, with all this spend on healthcare, well, we must be providing something better. At least people are getting better healthcare. Fortunately, that's not necessarily the case. We rank about 28% of 35 well-established countries across the globe. So when you look at the cost of what you're receiving versus what kind of care you're receiving, what you're spending versus receiving, we're an outlier. And I don't think that's any surprise to anyone here. So I do want to kind of not necessarily focus on all the problems we have, because you guys are doing such a great job serving your communities, especially over COVID-19. I just have to commend you for all the efforts you put in to really serving your communities. But I think this is more talking about healthcare as a whole and what can we do to be able to serve our communities better. So just kind of really pointing out where these costs come, and there's kind of 3 primary ones I want to focus on this afternoon. One being diabetes, so I'll kind of give you some information about what those costs look like. $327 billion annually on diabetes, about 34 million people, which is about 10% of the population. Additionally, there's about 3% who have undiagnosed diabetes, with about 88 million having pre-diabetes. Now, unlike many chronic illnesses, we think that must be for kind of an older generation, but unfortunately, we're seeing children with diabetes. It's very common. In fact, only about 27% of the population that have diabetes are over the age of 65. This is a major issue that impacts people of all ages. And essentially, medical expenditures for those who have diabetes are 2.3 times higher than someone who does not have diabetes. Next, hypertension, 131 to 198 billion dollars annually. About 116 million U.S. adults have hypertension. Of those, it's about nearly half the population. Of those, 92 million adults have uncontrolled hypertension. And then of those, only 24 million adults who have hypertension. The only recommendation we can make is make lifestyle changes. So about, in total, 1 in every 7 healthcare dollars are spent on heart disease. And then finally, COPD, $50 billion annual cost. more than 12 million adults. That's a third leading cause of 30-day readmissions, third leading cause of mortality in the United States. And moderate COPD can cause someone to live up to 6 years of their life in disability. So these are three primary kind of, we can almost kind of think about the causes for what are driving these costs to go up so high. On top of that, there are more Americans having these chronic illnesses. 117 American adults have at least one chronic condition, and 1 in 4 American adults have 2 or more chronic illnesses. And then of the Medicare age, 66% of them have multiple chronic conditions. Unfortunately, more people are aging into Medicare. 1.5 million beneficiaries will age into Medicare by 2021, every year from 2021 to 2029. And 83 million Americans will have 3 more chronic illnesses by 2030, which is a 171% increase from 2015. All in all, about 80% of inpatient admissions are for chronic disease patients. And then on top of all this, we're having a physician shortage, especially in primary care. So I don't try to say this to be negative, but I think it's really important for us to realize the state that we're in when it comes to healthcare. So the costs are unsustainable. We've pretty well established that. Is value-based care the answer? And it's kind of a tongue-in-cheek type of statement because it's yes and no. There is no silver bullet in healthcare. Healthcare is very complex. There's not one thing that's going to solve this problem. However, we do believe that value-based care can be a part of the solution. In fact, mid-pandemic, so this was, I think, July or so, Liz Fowler came out. She's the director of CMMI under CMS. I want to make clear that our commitment to value-based care has never been stronger. There's been plenty of other articles really reaffirming this, and this is really the movement that we're on. In fact, this isn't just happening now. Although we aren't fully in any type of value-based care scenario, in fact, only about 7% of healthcare dollars are spent in value. We've come a long way. So who remembers PQRS in 2006, right? How crazy was that to think back about that big change? But we've come a long way since then. You know, we've had meaningful use, stage 1, 2011, stage 2 in 2014. One little blip on here I just want to point out because it will be a focal point as the presentation goes on. But in 2015, Medicare Z codes were introduced. Anyone familiar with Z codes? They're tied to social determinants of health, and that's kind of precursoring what we'll discuss a little bit later. But we had MIPS and MACRA. We talked about that early this morning, 2017. And then, of course, COVID-19 kind of put a little bit of a speed bump on that progress, but we've still progressed. In fact, there's been other programs put out. We'll even touch on ACO REACH later in this presentation. This is a spectrum of value-based care. Value-based care is not binary. It's not you're either in or out. There are kind of different levels. But you see here, for those in the back, fee-for-service in the bottom left. It's really kind of where healthcare is today. Again, as I mentioned, about 93% of the healthcare dollars are fee-for-service. Now, I know some people may disagree with bundle payments on here, but it's really a spectrum. You don't want to think about it as, you know, we're either value-based care or not, but you can gradually move up these stairs, but I think you want to think about things 2 steps ahead, you know, and so I think that it's important to understand that this is a spectrum. There are even vendors here that Alidade and Privia, they might be able to help you out and kind of evaluating which one's best for you. But I think as you want to think about these steps, that there is a goal in mind, or there is a group that's doing it really well, and that's this group on the top right. This is truly capitated groups. I would not recommend anyone jumping all the way to the top step, but that's the purpose of this slide, is describing it is a step process. But the most important word when you think about this matrix on the far left being the degree of risk management versus the level of provider sophistication is manage a population. And that's really what we'll be taking the presentation from here. It's understanding what are groups that are doing capitation well, what are groups that are doing shared risk well, what are they doing, how are they helping patients, and how are they being able to lower the cost of healthcare and provide better care, as we've alluded to. In this analogy, just to kind of finish it home, I kind of like to think about it as there will be a point where there's a tipping point, and that, almost think about it as water, and you're going to have to move up these steps or you will be underwater. I don't say that to make anyone scare anyone, but for some intents and purposes, this will happen. Might be 5 years, might be 10, might be 20. I'm not entirely sure, but I think it's important for you to realize that we can't stay on this bottom step. It is something that we do need to start thinking about. So hopefully, as you guys leave and go back to your practices, you have some practical ways to be able to think about that. But talking to that future tipping point, in the yellow, you see the fee-for-service in our current state. we will reach this future state. It's just a matter of time. Even when we look at, this is from the American College of Cardiology, they talk about opportunities being the largest circle there. And those coming from medical home, conditioner, population-focused ACO, global ACO. So thinking about things in ACOs, I spent a lot of time talking with ACOs. That's the majority of the relationships and people that we're discussing things with. And I think it's really important for me to kind of take some of that knowledge back and describe it with you guys and kind of give you some of the secret sauce that we talk about. So I'm going to talk about two different programs that are a little bit more unique, but the goal is really providing person-centered longitudinal care for everyone. And we'll move away from some of the morbid discussion and move into some more positive ways you can impact the community. But I do want to kind of talk about two different programs, one being the ACO Reach. And so I think as we're thinking about these steps, it's also important to know and think about where's the puck going. I want to know what CMS is doing. So it's a new program released this year. It actually replaced another program and much better aligned, but it's called Realizing Equity, Access, and Community Health, REACH for short. As we mentioned, it replaced the global and professional direct contracting model, and there's some other key features, but I do want to kind of point some things out. This is, again, a brand new program. It's important to understand what is CMS, what are they trying to innovate with? What are some ways that they're really trying to change costs in a dramatic way? Here's a way that they're focusing in on more rural, underserved areas who would consider themselves serving underserved or rural areas here. All right. So one of the benchmarks for those who are serving the patients in the top decile will receive $30 extra per patient per month, per beneficiary per month. And for those who are serving the bottom decile, 5 deciles, it's a negative adjustment of $6. There's also some things you have to do around that they've made a cap on the risk score adjustment. But the biggest two pieces, social determinants of health. ACOs are strongly encouraged to collect social determinants of health data. This is where the Z codes come into place, and gathering this data is a critical first step to closing the care gap for this underserved population. And then all ACOs must develop a health equity plan and report progress and outcomes to CMS Innovation Center. So these are two things that are a part of this model that I think as we walk away here, we want to incorporate this in what we're doing every single day. It's not just about clinical care, which we'll get to here in a second. And then with discussions with the board and what we wanted to discuss today, the topic of specialties came around. So who here would consider themselves primary care? And then who would consider themselves a specialist? So actually, it looks like outnumbered specialists to primary care. So here's one program that's happening in Maryland. Maryland is total cost of care and doing some really innovative stuff when it comes to cost. But they have this episode quality improvement program, EQUIP for short. It's actually made for specialists. It's based on the Prometheus episode grouping approach. Who's familiar with Prometheus? If you aren't and you are a specialist, I'd maybe write that down and keep that in the back of your mind. That's how this is all based. It's a voluntary program, upside-only risk with savings accountability. It's aligned with the payer there in Maryland, and it is considered an advanced alternative payment model. So it's not subject to MIPS and gets that lump sum bonus. You can do a lot. There's innovation. Right now, it's currently for 3 different specialists, cardiology, gastroenterology, and orthopedics. And I've listed out some of the really important care measures that they're really focused in on. But later this year, they've already announced that they're going to be releasing this to 4 different new specialists. Allergy, ophthalmology, urology, and I think another one as well that's eluding me. So I think it's really important to know that this is not just going to be for primary care. There's going to be additional ways for you as specialists to be able to integrate this and be held accountable. And again, they're making it really low barrier to entry when it comes to just no downside risk, et cetera. All right, in order to succeed in value-based care payment models, we need to understand what it means to, as we showed there in that last screen, manage a population. So the term population health, it can mean a lot of different things to a lot of different people. The earliest known use of the term was in 2003. David Kinding and Craig Stoddard, some of the forefathers of population health, described it as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. Many complain, though, this definition was strictly on the measurement of outcomes. It didn't really acknowledge or explain the role that healthcare providers must take to impact those. So one quote I liked from Dr. Peter Slavin, they're doing a lot in Mass Gen and Massachusetts in general, but population health is the management approach So redesigning the care for a group of people with the aims of making their care better and more efficient. So when we think about value-based care and truly managing a population, that's really where we'll spend the rest of the presentation, is around understanding how to manage a population. So we've talked about population health from a definition standpoint, but the University of Wisconsin Population Health Institute had described it as the health of a community is determined by a number of health factors, including the quality of care, health behaviors, socioeconomic factors, and physical environment. In fact, they've taken these and they've actually established how counties' health rankings are set up based on these categories. So you think about, for those in the back, the policies and programs is there in the red. Those will hopefully drive health factors, and those will drive health outcomes. So they've broken these up. Health outcomes, length of life, quality of life, quantity, quality. I think a lot of the times in healthcare now we're focused on quantity, extending someone's life. But what about the quality? How are we helping these patients live a better life, a healthier life? And then we also have, when it comes to health factors, we've kind of talked about these before, but breaking it down further. In fact, they've actually kind of given associated percentages with these. Health behaviors being 30%. These are tobacco use, smoking cessation, diet and exercise, alcohol and drug abuse, sexual activity. So, in the EMR, these are actually been, some of the major measures that you're already starting to track. Then you have clinical care, which you guys are all very familiar with, access to care, quality of care. But then there's the tricky ones, right? So there's social and economic factors. This is 40%. This includes education, employment, income, family and social support, community safety. And then physical environment, air and water quality, housing and transit. So when we're thinking about things in the groups that are 2 or 3 steps ahead, you have to think about each one of these categories and say, what is capitation doing really well? How can we incorporate that in whatever type of programs we have today? So when I think about, say social and economic, it's being able to provide some type of community environment to be able to help these patients, maybe providing education, cooking classes, etc. When I think about health behaviors, being able to provide, diet and exercise, building a track for these patients to walk on, providing free gym memberships, things like to that extent. Physical environment, there are so many groups that I know that in, say, Florida or that are capitated that they find out that the majority of their patients are all living in an apartment complex and there's mold there. So they rip up the carpet, might cost a couple, tens of thousands of dollars to rip up that carpet, but it's hopefully, helping people who might have allergies to mold or might be able to have some type of have rent issue or replacing air conditioning units. And because they know that these are going to lead to, and it could be indicators for future health issues. So that's really the goal, is really help frame the mind and hopefully help kind of shift some philosophical changes in clinical care. Because clinical care, as we talked about, you're providing the best diagnosis, you're providing the best care at your centers. Everything is perfect. You're only impacting that patient 20% of their health factors. But if you think about it in the realm of capitated payments, you're fully responsible for their payments. And so, in like an MA plan, you might be receiving $800 to $1,200, maybe even $1,500 per patient per month. But if they go to the hospital, you're paying that. So it's really important to understand you are held fully responsible for the other 80% and your 20% of clinical care. And so I think it's really, really important for us to understand that. And so we'll actually use that as a transition to talk about how you guys can prepare and take into consideration the social determinants of health that we just discussed. So step one, the most important thing for you is to understand your patient population. So I think in general, we're starting to get a good understanding of how many patients we have that have diabetes, have hypertension, et cetera. But it's really important to understand where your practice is compared to the national data. And there are a lot of groups that can help you out with this. But if your diabetes patients is in the 40%, you might want to have a more focused diabetic program. If you have, and then you can be able to customize that as well. But how many of you know within 5% how many of your patients have poor health behaviors or socioeconomic issues? How many of your patients are unemployed? How many patients may have food scarcity? These are things that are currently not being documented, not being really incorporated in the care. But I think as we start the groups that are doing capitation well, the groups that are doing value-based care really well are taking these into consideration. They're trying to take control of it as much as possible. Unfortunately, it is very difficult. Patients are, in fact, we were having a conversation just last night. Americans, they eat too much, they exercise too little, and they know it. And I just thought that was so key. I mean, I think that's a huge thing that we have to fight against in healthcare, is just understanding that patients don't want to necessarily make that change. Step two that I highly recommend you starting to think about is assigning patient risk. And so the American Academy of Family Physicians really has kind of two outlined ways or models to think about this. Kind of a three-step model, a high risk, a moderate risk, and low risk assessment of that patient, or even up to a 6-point scale. And I think when I talk to groups that are fully capitated, they're doing outreach to patients, and they kind of call them strat 6, strat 5, and they're calling patients at this top level 6. They're calling them every single day, or they're stopping by, or doing whatever they possibly can to intervene and identify any needs that they have every single day. Strat 5, it's every other day. Strat 4, it's once a week. And so they're able to kind of really focus in on these high-risk patients, but they're not forgetting about level 3, level 4. These are really important, and we'll kind of get into here in a second what that means when it comes to rising risk management. I think anytime I'm talking with an ACO, this is the biggest piece that they are really focused in on, is the highest acuity of patients. These guys are the ones you hear their name all the time because they're getting admitted to the hospital and you're very familiar with them. But I think if you had the other 9 of 10 people standing in front of you, would you be able to decipher which ones are the moderate risk or the rising risk, as we like to call them? And this is what sometimes we refer to as the next 45. And this is really where you have the patients, they could go either way, right? So they could their condition could get worse, and they could be like one of those statistics that I mentioned at the very beginning of the presentation, or there's an opportunity for us to be able to identify their needs and intervene on these. But this is the best, low-hanging fruit, or, bang for your buck, low-hanging fruit, because you have an opportunity to be able to step in. So understanding their needs from a clinical perspective, as well as also the social determinants of health, and trying to help those needs. In fact, when you look at the return on investment, focusing in on this next 45, there's about 1.7x savings to impact this 45% versus the top percent. And that's really, as an organization, where we focus, but I think any ACO I talk to, they're really focused in on these rising risk patients. Step 3, benchmarking and comparing. So how does your quality performance compare to others? Everyone's been doing MIPS, and we heard about it this morning. It's something that's we can't pull back. We're in MIPS. We now have these measures, and I think the intention for MIPS was really an on-ramp to these advanced APMs. And so I think as you're starting to get used to this data, that people are starting to understand costs, they're starting to understand these quality measures, they're only going to become more heightened. Get used to these, get familiar with these, really understand how you compare it on a national level. So screening of future fall risk, when you think about decile 7, which we consider kind of where you would score in that 75% that we discussed, a great score there would be 78% or higher. But if you were to join an ACO, that national mean would be about 84%. So just know that bar is going to continue to get more difficult to get above. But it's really important to understand your measures and where they stack up. And if you weren't familiar with where this decile 7 scores were, or where the ACO scores were, you can at least see what that looks like here. All right, this is the good part. This is actually, I think we've all been in a lot of webinars together, but we all have some of the best healthcare leaders all in the same room. So I'd love to get you guys engaged and have you discuss a little bit of your best practices that you guys are doing around really 2 different topics. And these are both essentially value-based care programs that right now are currently being reimbursed on a fee-for-service basis, both annual wellness visits and chronic care management. Annual wellness visits is one of the biggest indicators for us to be able to focus in and understand on an annual basis what's going on with this patient, and not just clinically, but what's going on with their socioeconomic needs, their social determinants of health. So who here are providing annual wellness visits where it might be an initiative? So most groups that I'm talking to on the ACO level are aiming for 60 to 80% of their patients receiving annual wellness visit every single year. I'd love to hear from you guys, though. Again, this is we have some of the greatest healthcare leaders in Virginia in the same room. Does anyone have any best practices around annual wellness visits that they'd like to share? Some of the guidelines, they're covered. You can only provide them obviously once per year, so once every 12 months. There's no copay for the patient. And on average, they reimburse about $160 per patient. And so I think it's really important for this. I'll be honest with you, physicians don't like doing it. They want to touch, they want to feel, they want to prescribe, they want to be able to solve the problem. It's much more difficult. Now, I know when I talk to the ACOs, they highly recommend having physicians doing it. But who has a non-physician providing the annual wellness visit? A nurse practitioner, an LPN, something like that. What do those look like? Are they 30 minutes, 45 minutes, an hour? 40 minutes. Do you guys have a template, or how are you guys having them do that? Do you mind sharing there, Katie? Okay. So many groups are doing the pre-work. The physician still has to sign off on that, but most of them are having some of the other providers of care to be able to provide that service and really cover it. It's a lot of questionnaires. It's a lot of questions, but this is an opportunity for us to be able to spend more time, as we'll kind of talk about here in a second, identifying these social determinants of health. And then the second one here is chronic care management. Who here is providing chronic care management? It's for patients with 2 or more chronic illnesses, ones we kind of mentioned before. You spend 20 minutes with them per month to help them manage their chronic illness. We heard this morning, fee-for-service, a lot of those rates were going down. This is actually one that was increased this past year. So they increased it here in Virginia. I think it was $42, now it's $63.64. So CMS believes that this is really important as a program. It's one of the reasons I'm talking about it, is because it's really important for us to focus on. If CMS, it thinks it's valuable enough to be able to increase that reimbursement, then we need to follow the money and from that perspective and know that that's important to them. And that's kind of the secret to the program. To go into a little bit more depth on the annual wellness visit, when you actually think about what these templates that Katie was mentioning, you're providing a health risk assessment, the health status, injury risk, behavioral risks, urgent care needs. You're reviewing the functional ability and level of safety, such as hearing impairments, risk of falling, assess the ability to perform daily activities, bathing and dressing, and level of safety at home, right? Does this all sound familiar? These are some of the things that we're talking about when it comes to the social determinants of health. Providing health advice and referrals to health education and preventative counseling services aimed at reducing identified risk factors and promoting wellness. So health education, preventative counseling may relate to weight loss, physical activity, smoking cessation, fall prevention, nutrition, and more, right? So those were literally all the things that we just talked about all the health factors a part of the patient. So the annual wellness visit is just the one time per year that you're able to kind of focus in on all the different pieces, all the different health factors, as an opportunity to be able to set together a 5 or 10 year plan at that moment and be able to really impact this patient more than in the unique situations we're at the hospital. So really, I think at the focal point of what we're talking about when it comes to moving into population health, you want to move patients from a frequent flyer in the hospital to a frequent flyer in the outpatient setting, and that's really, really key. Another one is chronic care management. The benefits of the program, you reduce readmission. CMS has actually published some data, estimates that a high-functioning CCM program will cut readmissions by 23%. Improves patient outcomes, so you'll see HEDIS, EDS, your MIP scores all improving as well. Physicians able to see more complex patients, leveling the top of the license. So this is a big thing here. If your care navigators are reaching out to your patients, spending time with them, being able to help them manage their care, then when they come in to see the physician, there's less, oh, by the ways. I had this skin tag. Oh, I had this problem getting this situation here. You improve patient satisfaction. So I think this is a big thing from talking with other groups here is there's fear that there might be an Oak Street or a ChenMed or some of these innovators, even telemedicine online from a national provider. These are patients that we have to think about as consumers. And if somebody else is offering a gym membership and offering them these items, I think it's really important for us to be able to keep that relationship and make it a little stickier. And chronic care management can do that. Patients are more loyal and willing to remain with the practice because of it. And then you reduce inbound calls. That's pretty self-explanatory. So this is a program that we run, but our goal is really to help you guys be able to provide in-house if you want to. And that's really where we're going to provide some education at this point. There are two obstacles I want to point out. One is that there is a copay unless those patients are dual enrolled. So, from them, it might be $15, $16 for them that they're going to have to pay each month to be able to have this program. And there's been some legislation that might be waived in the future, but right now they have that copay. If I were to recommend anyone doing this program in-house, I would highly recommend focusing in on the dual enrolled patients because there is no copay for them and really, really easy for them to get started. They're going to want to. And then also, I think probably the biggest obstacle is that patients may not believe they need help, right? This is a Medicare age, and they're just a little bit more stubborn. I hope I'm not going to get killed for saying that, but I think it's really important to just kind of continue to have conversations with them, whether it's if they are stubborn around that, is having the physician bring it up, having the practice, hey, I noticed, you have these two chronic, have you heard about this program? Even rebranding it as a program that's not called chronic care management. That's highly recommended as well. So best practices for you to be able to provide chronic care management in-house. Some things we'd recommend is this being a full-time role. I will be honest, if it's a part-time role, it may not be consistent or effective. Groups that have done chronic care management before in the past that weren't successful is because they were calling 45 patients over here, 45 patients over there, and not really having that consistency. This one's debatable, but chronic care management care navigator should be physically removed from the practice. I think some people really do like having the care navigator meet face-to-face and having that familiarity. But I do know, and I think this is kind of where I would make my recommendation is, if they are there in the practice, there's going to be something that goes on fire, and they're going to be pulled into something, and then the next thing you know, the program's not there anymore. So by having the remote, you might even think about offering this as an additional, like a promotion, or for those who want to work from home or got used to it over COVID, you might see it as a promotion or a way for them to be able to kind of meet them in their needs of the healthy life balance and burnout. Care navigator, as you're reaching out to patients, it's really helpful to track trends of what's happening with your patients specifically. If you're realizing that they're running into some social determinants of health, like as I mentioned, the moldy carpet or the air conditioning, you might want to have, hey, let's go ahead and work alongside this church group, this community service, and see if we can do something about that. But unless you're tracking, unless you're understanding where those trends would be, it'd be really hard to intervene on those needs. And then this program is meant to keep patients out of the hospital, not following up with patients who left the hospital, like a transitional care management. That's a great program, and I think every group should be doing it. But I think it's not this program. This program is really to help patients, those rising risk patients, be able to stay out of the hospital. This is what we do. So I'm going to provide some data, and I think the reason I think the mindset that I want to help frame this around is that find different ways for you to be able to provide the same interventions. It may not be over a 20-minute call every single month with the patient, but what if there's some way that you can identify these needs while they're there in the visit, there in the office? Here are some of the most common interventions that we've done. Again, this data is from about 9,000 encounters from 4 different practices that we work with over different states. But I think the biggest interventions around appointment, education, and medication. So the top 5 education interventions in 2021, you want to guess what was number 1? It was COVID. I think there's a lot of misinformation, and I think by being able to provide information to patients to understand the risks, what's the risk of this versus that, and allowing them to be able to make a better educated decision, that is really important. Diet's a big one. There's so many times where our physicians recommend having a low sodium diet. Patient takes the salt shaker off the table, they think they're compliant, but then in the meantime, they're ordering Chinese food or eating frozen foods, and they are defeating the purpose. So half that is also just explaining and providing that education. Hydration is a big one too. You might even want to have this conversation there in your practice to help educate them on hydration. It's obviously 70% water in our bodies, and that's something that I don't think people always think about, especially as we consume more soda and coffee. I know I've already consumed a lot today, so I need to take my own advice there. Activity and exercise. So this is kind of, as I mentioned, some groups are building like a track near their facility, or finding some way to be able to help these patients be able to be more active, or just encouraging them to be able to maybe take a baby step somewhere, maybe start walking to the mailbox, and then start walking around the block. And next thing you know, they really enjoy it. They like doing it. There's many times even where we've realized that a patient they might have had a no-show. We weren't sure why they didn't show up. So we had that conversation, tried to identify those needs, realized that they lost a loved one. And so finding them and actually adopting a dog for them for them to be able to start to feel re-energized, not just from exercise and ability there, but also a new sense of living. And it's so exciting. Like just being lonely can make patients start to feel less wanting to be active or have a reason to wake up every day. And then appointments. There's other things, the education around appointments that we can do, but that we'll talk about here on this second slide from here. And then medication. Before joining this organization, I was so surprised that Medicare adherence was such a big issue. So I think it's important, even if you don't do chronic care management, to have someone reach out to the patient. Hey, did you get the prescription? And I think it's really important. There's so many obstacles, either transportation to get the prescription, or they just realize that there's a higher cost, and there's a lot of pharmacies, obviously, that will work out programs with the patient. So making sure that they take their medication and following up with them is a huge way to be able to intervene on these readmissions. Refill requests, confirmed supply, access to pickup. There's even opportunities, different organizations that will actually come and pick up and drop off the medication for the patient too. And then finally, around appointments. Obviously, there's appointments setting up with the PCP, but there's also opportunities to set up meetings with specialists. And then most importantly, quality appointments. This is actually where you can set up annual wellness visits and schedule those. I think it's really important. You see all the different options there that we are able to intervene on, mammograms, et cetera. But it's really important to be able to fuel that some way. So I don't know if there's oftentimes I talk to people who are doing annual wellness visits, and they say, our docs, they say, hey, I get it, annual wellness visit's great, but I'm just going to do whatever's on my docket. I'm going to do whatever's on my schedule. So actually having somebody call the patient and say, hey, it's been over a year since we've had your annual wellness visit. And most of the ACOs I talk to, they say that's the biggest thing. It's not actually the doctor getting them on board. It's getting the staff and getting them to schedule it. So that's really important there. But those quality appointments that can actually be led by your staff. And then lab work and physician behavior. Behavioral health there at the end. When it comes to, so all this, to kind of go big picture, we have, as we just kind of in review, we've talked about value-based care, managing a population. We've broken down what managing a population is, but why are we trying to do these interventions? Well, the cost economics of it will actually make a change. So I kind of just taking one scenario here, specifically around fall risks. So if you had 10,000 enrolled patients and you were able to, there might be, I think based on the stats, about 2,840 fall risk patients. And then of those, if you were able to provide 97% of them fall risk assessments, you could provide 385 associated interventions, about 14%. And you would avoid about 38 falls. This is some data, and I can be happy to get just the data afterwards. But for a hip fracture injury, you're talking about $37,000. So if you're able to avoid 38 of those, and actually you'd be able to reduce your PBM by $6 per patient per month. Now, again, this isn't a lot, but over the population, because you're looking at $684,000 total. We need to think about the 18,000 by 38 falls. So all in all, I think this is when we talked about costs, we saw these costs going up. This is how we're going to be able to curb that. Again, part of the puzzle. There's no silver bullet in healthcare, but I think it's important for you, if you can be able to provide fall risk assessments at your practice, if there's some way, whether it be through a 20-minute call with the patient or some other way, you can be able to lower the cost. And ultimately, you're going to make more money if you're in some type of at-risk agreement. That's what we're going to get to here in a second. So just taking chronic care management as an example, we talked about the reimbursement going up in January, but if you were just to do the program and you just reimbursed for that 99490 code, you'd make an additional $100,000 as a practice. If you were to not bill for that code and be in some type of capitated arrangement, you actually would make an additional $20,000. And I think that's the key here. It's not about chronic care management. It's not necessarily about annual wellness visit, but it's really about thinking about there is savings that you're creating in a fee-for-service world, but you're leaving the money on the table. Either the government's making that money or someone else. And so you should be able to get what's yours. And I think that's really important and why I describe it here. What other programs should you keep in mind? So the couple other opportunities, patient-centered medical home. Anyone a PCMH? Yeah. How long have you been a PCMH, Deidre? Yeah. Were you already doing a lot of the things already? You see a lot of benefit for your patients, would you say? Yeah. Who here is doing principal care management? Okay. So this is really focused on a specific care measure, and I think it's really important, especially as we talked about specialists and getting them involved and really taking ownership of that full 100%. It's really important. Who's providing transitional care management? His hands. Okay. Yeah, that's a phenomenal program, really helping these patients as they leave the hospital, getting acclimated to their environment again, and making sure that the same situation is not happening again. I think it's really important. It's reimbursed fairly well as well. I'm not as familiar with the program as well as I do the others, but transitional care, do you want to mention anything about that? Anyone who's providing that service? Yep, Katie? Anything you want to talk about, like the benefits of the program, what that workflow looks like?
Right, just patients that have been in the hospital, getting them seen in the office within 1 or 2 weeks to make sure that they're understand their discharge summary and discharge instructions, reconcile their medications. They often get put on the medication that maybe they aren't on, making sure that they don't bounce back into the hospital.
Great, you nailed it there. Yes.
I worked with practice that did, that had chronic care management. One of the benefits that we saw with it were when those nurses make that call within X number of hours from getting out of the hospital. A lot of times patients are so confused because they got so much going on in the hospital. So to have that nurse that knew them with their practice go through that list of medicines, make sure they were taking what they needed, and actually take it to the next step other than getting the thing at the hospital saying, she'll get you out here in X amount of days. So people really seem to appreciate that follow-up from the primary care standpoint. Hey, I was in the hospital, wow.
Yeah, really good point. Yeah, there's a lot going on, obviously, in their life. And to get all these instructions, and they don't really know what to do when they get back, so they just don't do anything. So unfortunately, it does help. I know some groups are even going on site with them and staying at a hotel not far by, and as they wake up and as they go to bed, just making sure that they're and again, these are in these capitated arrangements, really making sure that these lifestyles are changing and the patients have what they need. One program I really liked, Familiar Faces program at Vanderbilt. Heard about this at NACOS, but they had actually a primary care physician there at the hospital. So when that patient went to the hospital for whatever reason, they were connected to a primary care physician right then and there, and they actually were having kind of a annual wellness visit right there at the hospital. As they obviously were sitting there and recovering already. So I think it's really important to be able to identify these needs and intervene as often as we possibly can. Geriatric emergency department. I don't know if anyone has a department like that at their hospital. One for the pediatricians in the room. Who here has heard of ACEs or ACE? It's an adverse childhood experience, and essentially it focuses in on kind of like an annual wellness visit, but it's really understanding the child and what type of traumatic experiences they might be going through, and thinking about in like an opportunity for behavioral health, or to try to understand where these patients might be at a very early age, might need some additional help. And I think that's really the key to what we're talking about is right identifying needs early in risk and being able to intervene on them as quickly as possible before it gets to the point where there's not much we can do about it. And then a program I really liked from Aladane, Healthy Holidays, essentially sending out a postcard to the patient, letting them know about their holiday schedule. And hey, why don't we go ahead? These days are going to be closed. Why don't we go ahead and schedule your annual wellness visit now? Let's go ahead and get these visits scheduled. And then they put it up on their refrigerator and they see it. So, we're staying on top of mind with the patient too. So these are some other opportunities. Again, I kind of wanted to offer some questions here at the end. But just as a summary, the cost of sick care, fee-for-service, is not sustainable. Value-based care shifts risks from the government to physicians and commercial payers. And then with the responsibility of patient risk, it's imperative for physician groups and health systems to truly manage all health factors of the population, and then find as many ways as possible to identify and intervene on that risk as early as possible. And then here's two programs that leverage fee-for-service, even though they are value-based focused: annual wellness visit and chronic care management. So that's the summary. I'd love to take some questions, though, if you have them now. Any questions about chronic care management, about the annual wellness visit, or anything you want to be able to talk about with each other here while you have everyone in the room? If not, you can email me at michael.dudley@goodinhealth, or better yet, I'd love to get connected with you on LinkedIn. I do like to share patient success stories that we have with our patients and other programs. So, yes, Donna.
We had a couple people ask about slides. Jody sent in a welcome email to everybody this Thursday morning about the conference. It says conference resource page. If you click on that, or you can log in to MemberClick, their site, you can look up Michael, and there's a tab down there, PDF, and you'll have all the slides and the other ones that gave slides.
Yeah, or you can email me too. I'd be happy to put them in a Google Drive and email you the link. But thank you guys very much for having me. It's been an honor to be with you this afternoon.